Hi, everybody. This is a video, your first one on classification and diagnosis. Okay, so a little bit of history about classification and diagnosis would include the observation that there have been attempts throughout history as long as 3,000 years ago, 5,000, 3,000 BC, with the first written description of a mental disorder that may have been very similar to what we, a number of decades, called a senile dementia and old age, loss of cognitive functioning. More recently, there have been efforts within India to look at the types of what they thought were demonic possession. But really, the question would be, why diagnose anyone? And if you can think of some reasons before you continue with this video, that would be useful. Why would you diagnose anyone? What really do you get from that? Okay. Well, there are some advantages and disadvantages, aren't there? One of the advantages is it allows you to have more efficient communication with other clinicians. You don't really have to go through a long litany of symptoms. If you have a name or a coding for a diagnosis, you can communicate that and be somewhat precise with other clinicians. Another advantage would be it provides treatment direction, where what do we want to do to treat this individual? Yes? And then it allows you to evaluate and compare what the treatment outcomes are based on what you're doing with patients who have a particular disorder, and that helps us narrow down what works best and what doesn't. It also helps the family and maybe the client as well, who may really, and often does, want to know, what's the problem, what's the issue. The family may want to know that. So those are advantages, and in the disadvantages, we include things like the labels that may persist. It's unfortunately not terribly uncommon that clinicians don't put in remission or carefully document that the client no longer has a particular disorder because they've completed treatment with a good outcome. And people may really not like that. There can be errors, subjective errors, particularly among inexperienced clinicians who are not particularly well trained in diagnostic procedures. It may cause unemployment to be denied, depending upon what the diagnosis was in their past, if they're seeking employment in particular ways. So that would be true of certain government positions or sensitive positions and so on. And there may be a cultural stigma about seeking help. There certainly is one in general, though it's less so, particularly in this country. But there is a stigma attached to getting help. So becoming a really good, if not superb, diagnostician involves much training and experience, supervised training and supervised experience. You'll get that if you're going for a license in a mental health field, but it's important to continue that process to learn what you can, everything you can, about diagnosing, and picking apart the differences between one disorder and another, and being broad enough to be able to catch things that are not typical. Right? So the old medical school saying is, if you hear hoofbeats, it's almost always horses coming, but every once in a while it'll be a zebra. Yeah? This is an area of diagnosing where clinicians often do more poorly than they probably should because of the lack of training. There's not a lot. Generally speaking, there's only one course in abnormal psychology in graduate school. At least at the master's level, there's only one. You'll get more if you continue on to a PhD. But in my humble opinion, in my clinical experience, both, this is more art than science. It's underlain by a science of organization and results from lots of testing and survey and so forth, but diagnosis is I think more art than science. Okay, I'm punching the move forward button to follow the train here. So a few terms are important to know about. The first one is called epidemiology, which is a study and distribution of mental and physical disorders within a population. And you can actually get a PhD in epidemiology at OU Health Sciences Center. And it will teach you lots of interesting things. And one of the things that it's very keen on is the statistical analysis that will give you the most important information about the distribution and related issues in a population for diseases of any kind. Prevalence refers to the percentage of a population that exhibits a disorder during a specified period of time. Okay, a lifetime prevalence, as the name suggests to you, is the percentage of people who have been diagnosed with a specific disorder at any point in their lives. So lifetime prevalences are usually higher than particular moment in time prevalences. That's not always true, but often. And etiology is the study of the origins and causations and developmental history of an illness. A few more things are prognosis. That's, what's the probable outcome? What's the forecast of what will happen if you treat it versus you don't treat it? Okay. And then severity. How severe is it? We've talked about calibrating mental disorders from having none to subclinical to mild, moderate, and severe, and then some people think there's an extreme category. Okay? So it's the degree of symptoms present. Sometimes severity refers to the degree of impact. And that a disorder has. Comorbidity is the last term I want you to be familiar with, and it basically means the presence of more than one disorder. So depression may also come with an anxiety kind of disorder. Depression may come with a substance use disorder, you see. Okay, so what would be comorbid with this? And you look for those other things, or make sure you were aware of that. Okay, so the list of these disorders is called the Diagnostic and Statistical Manual of Mental Disorders, and there have been editions from number 1 in the 50s to the 5th, which came out in 2013. That's the current issue. The next one might be 5.1. I'm kind of excited to see if it's not the 6th, but rather 5.1. So this is a compendium of all the agreed upon, driven by science, all of the disorders that we name. And so this changes, and there are reasons that are logical for making the changes. So there may be one classification of disorders that exists that didn't before, when we have more research to support that kind of development. There may be certain disorders that move from one category to another when we learn more about the dominant symptoms from research, and so on. The DSM is a descriptive catalog. It talks about observable behavior plus a client's subjective experiences. That's important, because those are the things that you don't observe, those subjective experiences. It takes the medical model. So what that means is that mental disorders are in fact diseases, and it basically takes a non-theoretical approach. It does not talk about the theoretical origins, and in fact it does not talk about causes and origins. There are so many possibilities for everything, with a very few exceptions. So it's really, there's much speculation and not as much concrete results from research about causation. Now, it's listed in categories. So there are, for example, anxiety disorders, depressive disorders, dissociative disorders, and so forth and so on. And it's really useful, because it talks about things like culture-related issues. It talks about not just the diagnostic features and criteria, but it talks about gender-related distinctions, differential diagnosis, which is how to tell it apart from other things that people often confuse it with. That's really important. That's been around in the DSM for quite a few versions. Prevalence, how common it is in a population, lifetime prevalence, risk and prognostic features, and the risk factors are really relatively new. We have a lot more research directing us to specific and general risk factors for virtually all the disorders, but not all. For some, we have lots of good stuff, and others, that's relatively recent. Excuse me. Now, you might expect, because most books that are encyclopedic and textbook-like kinds of publications get bigger with each edition. That's absolutely true with the DSM. It started out in 1952 with 60 disorders, and now in 2013 there were 370 disorders and 947 pages. That's a big difference, isn't it? Yeah, it is. Okay. So there are some, as I said, minor revisions from what was then the DSM-4 TR, which stands for Text Revised, which was something that came after the DSM-4. And they combined certain things. They removed what was called the multi-axial system. I kind of liked that. I bet a lot of clinicians who were used to that liked it. They removed it. They changed the name of some disorders. They reorganized them. For example, PTSD is now in what we call trauma and stressor-related disorders, a new category. Yeah, so a lot of interesting changes. When used properly, and when diagnostic procedures go well, then it improves the reliability not just of the diagnosis, but of the treatment that's offered, and the validity of the treatment that's offered, really, as well as the reliability. Excuse me, I my eye. It creates greater uniformity among clinicians. Absolutely, it does, and it is really creates direction for better science. So when we all do our jobs well and report well, we help the profession immensely. Okay. What are some of the limitations of the DSM? Good question. Glad you asked. Well, you can over-pathologize. You can see pathology where there isn't any, and that has to do partly with understanding the sensitivities of diagnosing and understanding the thresholds for symptomatology. In other words, how much of these and how many and for what duration do these symptoms have to exist for you to pay closer attention to the possibility that they are pointing you in this direction versus that direction. This is particularly true when a person has more than one set of symptomatology. So this gets rather tricky, and that's kind of interesting, isn't it? Yeah. Diagnoses can and do, in some ways, limit us to prevailing cultural norms and directions and attitudes, really. I mean, we're all part of our culture, so we do our best, but we are limited to that. It creates the illusion that we are objective, and that's an illusion. It also creates the illusion of universality, which is an illusion. It's not universal. I mean, if you look at the French version of the DSM, which is actually different than that, quite a bit in many different ways, in interesting ways. It could be a good course, wouldn't it? Okay. So there are lots of categories in the DSM-5, and I have a listing of those on your PowerPoint, and we've talked about those. I want you to just read through them. And the last thing I want to talk about is I want to put it on the next video, okay? All right, see you in a minute.